Good afternoon and welcome back to continuing the conversation with Dr. Thrower on reversing disability in multiple sclerosis. This webinar was started last month, is now on our YouTube channel. For those of you who do not know Dr. Thrower, which is probably very few of you, Dr. Thrower is the medical director for the Andros C. Carlos MS Center at the Shepherd Center in Atlanta, and he is also our senior medical advisor with MS Focus. So I'm going to turn it over to you, Dr. Thrower, to just recap what we talked about last month.
Great. Good afternoon. Thanks, Sherry. Thanks, Flavia, for all the help. So just to recap briefly what we talked about last month. So neural repair is the idea of fixing damage, whether it's remyelinating or repairing axons. Neural plasticity is the idea of forming new pathways. There are things in the human body that seem to inhibit repair in the brain and spinal cord. And so one area of a lot of research in neural repair and plasticity is how do we overcome some of those natural inhibitors of remyelination? And some of the pathways that are being explored are things like mesenchymal stem cells. There is also autologous stem cell transplantation. Sometimes some confusion about those two different types of stem cells, but refer back to last month's program for some clarification. There are numerous trials going on. We have a trial called PIPE 307. There's a medication called vidofludimus that is being looked at for neural repair. There are studies looking at repurposing known FDA-approved molecules, things like clemastine and metformin, to see if maybe those play a role in remyelination. Along the front of neuroplasticity, there is a device that got FDA approval last year from a company called Helius. It's the PONS neural stimulator, which along with rehabilitation may play a role in helping form new pathways and improving function through those pathways. And then I think we closed up on just rehabilitation in general, and how important it is for people with MS to stay as active as possible and look at rehabilitation where appropriate, because we certainly can improve function in some cases through rehabilitation. Whether that's actually repairing damage is not entirely clear, but there is some evidence that maybe we're helping form new pathways or promoting neuroplasticity through aggressive rehabilitation. So with that recap, we will turn it over to Q&A and see what's on folks' minds.
Okay, Michaela is asking, do you have any other strategy recommendations for everyday MS patients to improve neuroplasticity and reverse damage aside from wellness, exercise, DMTs? I'm doing all of the above, but curious what more I could be doing. Perhaps supplements or other habits? I assume there's nothing that can be done about black holes seen in the brain MRI.
So nothing yet that we can do about the black holes, but again, just don't sell yourself short on the importance of the exercise and where appropriate physical therapy, occupational therapy, those things that you're doing. If you feel like your exercise routine has gotten stale, it may not hurt to work with an exercise physiologist or trainer who has some knowledge in MS, or a physical therapist, to kind of throw some modifications or challenges at yourself. Because again, we know that people with MS can decondition very quickly. So even if it feels like you're plateaued, I can almost guarantee someone like yourself that if you weren't doing what you're doing, I think you would probably see some loss of function or decline if you weren't putting in that hard work that you're doing. Talk to your healthcare team and see if there are any studies going on in your area that you might participate in. We do have some people who are using clemastine off-label. This is an antihistamine that's shown some promise in very small studies at University of California, San Francisco. It's a very mixed bag with clemastine, and that some of the initial studies in individuals with optic neuritis did show improvement in visual function, but then there's a multi-armed study looking at several different off-label drugs, clemastine being one of those, and the clemastine arm was actually stopped early in this study because 3 individuals with MS actually had a worsening of their neurological function. There's debate about whether that is significant or whether it was a statistical fluke. So, I mean, you can certainly have that discussion with your healthcare team about whether clemistine might play a role in your situation.
All right, I have a follow-up question from Michaela. She's heard you speak in the past about neural reserve, and she's curious of how smoldering inflammation relates to neural reserve.
Yeah, so I think, the neural reserve is the concept that, how much can I injure my brain or spinal cord, whether it's through MS or stroke, and I get away with it. So I've had an injury, but I have enough backup in my brain or spinal cord so that I don't lose function from it. The challenge with neural reserve is that we all start losing a little bit of it as we age. So when we talk about neural reserve and smoldering inflammation, I think those are part of the larger conversation of PIRA, P-I-R-A, progression independent of relapse activity. So this is the individual with MS who has a stable MRI, they have no relapse, but they feel like they're just progressing some. And we think there may be 2 potential explanations for that. One is loss of neural reserve due to just normal human aging, and the other is this smoldering inflammation. Smoldering inflammation is, we think, driven by cells in the brain called microglial cells that are normally good guys. They're garbage men, if you will. They clean up debris and cellular tissue that from damage. But it looks like they can sort of shift gears and become drivers of low-level inflammation. We'll see where this whole concept of smoldering inflammation plays out over the next months and year or so. There's a class of drugs called BTK inhibitors that we're all watching closely, that oral medication that may address smoldering inflammation in a way that other drugs haven't. It's been a very mixed bag in the research with those drugs. There have been now 2 studies that have been fairly underwhelming. One just came out last week in relapsing forms of MS, really not showing that the 2 they looked at, 2 BTK inhibitors, were much better than teriflunomide or Aubagio. But there was also a study last week in secondary progressive MS without activity that did show that tolebrutinib, one of these BTK inhibitors, did seem to slow progression in that group of people. So stay tuned on the BTK inhibitors and smoldering inflammation.
Maureen is asking, is there a time limit for how long ago the axon damage occurred for the treatments to work? And she's stating 30 to 40 years, question mark.
So we don't know the answer to that. I think intuitively we would think the more recent the damage, the better. But in some of our studies looking at neural repair, for instance, in one of our mesenchymal stem cell studies, there was no time limit. There were limits on age and level of function, but there were no time limits on how long the disability had been there. One of the concerns about maybe damage having been there longer is the concept of gliosis, or scar tissue forming around the site of an injury. So if you damage the myelin and the axon, and now you have scar tissue that forms around that, is it going to be harder for some sort of repair mechanism to fix that damage if it's sort of, if you will, set in concrete? So one of the other areas of research in repair is, are there things that would actually sort of help clean up that old gliosis and create a fresher environment so that repair might be more able to occur?
Okay. I have both Mike and Julia asking questions about the cyanic neural sleeve, and both wanting your opinion on it and whether or not the sleeve does the same thing as other neuromodulators that have been discussed in the past, like the walk aid.
Yeah. So all of these, so the Bioness device, the walk aid device, the Psyonix neural sleeve are all examples of these functional electrical stimulation devices. So they're basic. If I can't get the signal from brain down to the peroneal nerve to control my ankle dorsiflexors or bring my foot up, I'm just going to bypass the brain and spinal cord and use this external device. I think they're all potentially viable. I would say from our standpoint, we probably use the Bioness device a little bit more. And it's a matter of practicality. Our therapists can put that device on someone when we have trial units and sort of see if it's going to do what we want it to do. With the Psionics neural sleeve, because it's custom fit to your leg, it's hard for a physical therapist to just pull a small, medium, large off the shelf and let you try it out. That's not to say that the device isn't worth a try. It's just a little different pathway. You're going to have to sort of work with the company, with Psionics, do the measurements, get the device, and then try it out. Ideally, I'd love for people to try it out with the guidance of a physical therapist, so we know that we've got everything put on appropriately, and that you're getting the best trial possible. But yeah, we have numerous patients who are using the Psionics neural sleeve. I would say people have been pretty happy with it, just like they are the other functional electrical stimulation devices.
Karen's asking, has nerve damage ever been successfully reversed historically?
So we're certainly seeing glimpses of positivity. Again, if you look at the Clemistine study in optic neuritis, when they treated individuals with prior optic neuritis with this oral antihistamine Clemistine for 6 months, the speed of conduction as measured by a test called visual evoked responses got faster. After that same research group did a more sensitive MRI technique looking at kind of how water moves between sheets of myelin, and this is a measure of myelin repair. And they showed in the same group of individuals that there was, with this MRI measure, evidence of myelin repair. In some of the mesenchymal stem cell studies, there have been, some positive results in some of these trials looking at improving function. So it's certainly not as easy as the peripheral nerve. So the central nervous system does behave differently from the peripheral nervous system. So, and there are numerous challenges in the human body as to why we don't repair myelin and axons better. But I think we're on the right path, and there have been some positive results in trials to date, and I think we'll see those going forward as well.
As a follow-up on that, Julia is asking if there are any new trials on medications to reverse MS,
Yeah,
also maybe to repair myelin.
Yeah, so the PIPE and I think it's 307 study is ongoing right now. I would encourage people to go on clinicaltrials.gov to stay really up to date with any trials that are recruiting. So you can, on that website, type in multiple sclerosis / remyelination, and you'll see any studies that are potentially recruiting at that time. The National MS Society website does a pretty good job of mentioning actively recruiting trials. So yeah, use all your resources. It's almost impossible to know, and I think this is a blessing and a curse. It's almost impossible for any one MS center to know everything that's going on out there. So we usually know our geographic region, as to what trials are going on. But sometimes there are small investigator-initiated trials that may only be at one site, and we may not be aware of that study. So again, it's good to go on some of these websites and see what's going on in your area.
Also, might be wise to just remind folks that when things are in clinical trials, it depends on what phase they're in. A clinical trial takes an average of 10 to 15 years from the beginning of the trial. So if you see something that's phase 1 or 2, it's not going to be something you're going to see on the market for at least 5 or 7 years. So if you're seeing something like that in the literature, just be aware it's still early trial. It needs to be a phase 3 or going to FDA approval from it.
I think that's great advice. And I think that, if you even back it up a step past that, if you see, animal trials, so, we use the mouse model for multiple sclerosis. If you're really interested in research and you just want to know what's going on at the animal level, by all means do, but always just be cautious, because that animal model ultimately is not a human, and we've had a lot of examples of things that worked and looked very promising in the animal model that didn't ultimately pan out into humans. So sometimes you can go down these kind of rabbit holes on the internet of looking at animal research that is interesting, but it may not be something applicable for a while, if ever.
Okay. Deborah's asking, is extreme itching a result of inflammation, and have you seen this as a reaction to Ocrevus?
So infusion reactions are one of the most common side effects with ocrelizumab or Ocrevus. And it usually manifests as either itchy throat, itching in the skin, itching in the ears. And so certainly let your infusion team know if you're dealing with that. We usually want to shut that down as quickly as we can, either by giving extra pre-meds or slowing the infusion rate down. So yes, that is a common side effect with ocrelizumab infusion.
Okay. Karen is asking, can lowering inflammation with a GLP-1 medication possibly help with remyelination? Anecdotally, see your patients on GLP-1 having lower MS progression, and is anyone doing research in this area?
So I know they're looking at that other potential benefits from GLP-1 medications. I know there's been literature looking at, for instance, heart disease, and there do seem to be some cardiac benefits from the GLP-1 drugs. I mean, we certainly have a lot of individuals with MS who are on these medications. I certainly have not seen anything negative. That's a question that comes up sometimes. Is there any medical contraindication? And we have not seen any negative effects. I think it's too early to know from a in the trenches real world standpoint if we're seeing improved function. I think improving health and if you have mobility issues, carrying extra weight does add one more challenge. So I think sometimes there's an indirect benefit just from losing weight and having better mobility. I don't know of anyone right offhand that is doing that research, but I would feel almost 100% confident that someone's looking at that for the very reasons you asked. If they are anti-inflammatory, how broad is that anti-inflammatory effect, and does it benefit things like multiple sclerosis?
Larissa has her hand up. Larissa, you can go ahead and unmute and ask your question.
Hi, thanks. Is there any evidence of lifestyle changes like diet on 2 points? One, decreasing inflammation, and 2, helping to reverse any kind of disability?
So yes, on the first part. So there are studies that have looked at various diets, from Mediterranean diet, intermittent fasting, and some on the paleo Walls type diet, showing that those diets were associated with a decrease in inflammatory cytokines, which would imply that there's an anti-inflammatory effect. That same sort of research has been done with exercise in MS. Showing that these inflammatory cytokines can be downregulated to a certain degree with exercise. How much does that translate into a real world clinical benefit? I don't think we have the final answer to that. I do think that we see this with highly effective disease modifying therapies. If you look at, say, natalizumab or the B-cell therapies, there's always a small population of individuals that start one of those drugs and they do better than stabilize. They seem to actually improve in some way. And I don't think that improvement is necessarily due to a direct reparative effect of those drugs. My suspicion is that if you stop an active inflammatory process, you probably give natural repair mechanisms a better chance to do their thing. And you would think intuitively that should apply to lifestyle changes that decrease inflammation. Maybe there is a better chance for natural repair mechanisms to set up shop.
Thank you, Larissa. I'm going to mute you again. Aurora's says 20 years ago, there were some studies showing cannabinoids stopped demyelination in mouse studies and then caused remyelination. Has there been anything more on cannabinoids and remyelination?
There are studies looking at ongoing. I think one of the challenges of looking at cannabinoids as a disease modifying therapy or as a neural repair, mechanism, is some of the studies they've been small primarily, and they've tended to look at individuals with fairly advanced disability. And so it may be that if we did studies and we looked at people earlier on, maybe we would see something. I think the simple answer is yes, we're looking. No, it's not been proven. It's really, enticing to think that it should be there, because if you look at the CB1 receptors in the endocannabinoid system in the central nervous system, I mean, there should be some sort of neuroprotective effect. If you look at CB2 receptors in the endocannabinoid system in the immune system, every immune cell in the human body has a CB2 receptor, so they appear to be anti-inflammatory. So it's kind of intuitive to think there should be something there, but we've not been able to prove it yet.
Thank you. Melissa says, if you cannot get an MRI with contrast, can you see exactly how much damage is done to the myelin sheath and beyond, where there is a chance of repair or too much damage for repair?
So I would say there's a difference between MRI with contrast and no MRI at all. So in a lot of times in clinical practice now in MS, in individuals who we're doing monitoring MRIs on an annual basis, we're dropping the contrast in a lot of those individuals. So with newer technologies in MRI and newer techniques, we're really seeing most of what we see without the contrast. What the contrast really lets you do is it lets you tell you if the blood-brain barrier is leaky. And so if you see a new lesion, you can help date it. Is it acute? Is it subacute? By giving the contrast. But that's really probably the only thing that contrast adds to the equation. So I would say a lot of our MRIs now are without contrast because of the advancements in technology. If you can't have an MRI at all, I think that's a different story. And there are individuals that can't for whatever reason. They've got extreme claustrophobia or they have a pacemaker in place, and we just have to do the best that we can. I think with the advent of serum neurofilament light chain testing, I think it gives us one more potential window into neuronal damage. So neurofilament light chain is the protein matrix, if you will, that makes up the scaffolding or the framework of a neuron and the axons in the central nervous system. If those cells are being damaged, that neurofilament light chain is sort of scattered into the spinal fluid and ultimately into the bloodstream, where we can measure it in serum. So we are using that as a kind of one more biomarker, if you will, to look for neuronal damage. And you could use that blood test in a number of ways. Someone who's newly diagnosed, maybe you get a baseline before they start treatment, you put them on treatment and it shows that those levels are going down. If you're looking at an older individual where you're de-escalating therapy, maybe you get a baseline before you stop their treatment and then you monitor it off of treatment. It's one more reassuring measure that there's not ongoing neuronal damage as measured by that blood test.
Thank you. Alicia asks, will estrogen help with declining disability, and how old would that not be recommended? Would there be any benefit?
So most of I think that the strongest evidence for where estrogen, specifically estriol, might play a role is in pregnancy. So we know that pregnancy seems to have this protective effect, especially second and third trimester of pregnancy, and that's the time when estriol levels spike in women. Other than pregnancy, most of the estrogen that women have in their system is estradiol, which doesn't seem to be a big player, good or bad, in the MS world. We have questions that come up around menopause and postmenopausal hormone replacement. For right now, what the research would suggest is that decision of whether you should use hormone replacement in the form of estradiol, maybe with or without progesterone, can probably be made independently from the MS diagnosis. So if you're highly symptomatic, postmenopausally and hot flashes and whatnot, then it's certainly okay to start a hormone replacement. But at least right now, we don't see that those hormone replacements are inherently good or bad as it relates to where we're at with MS.
Thank you. Carrie wonders if you've seen the spinal cord stimulator helpful getting the message to muscles for foot.
So spinal cord stimulators are primarily used for pain management right now. There's not been a lot of when we think about improving muscle function or getting the signal to muscle, most of those devices are external, things like the Psyonix neural sleeve, the Bioness device. What most of the spinal stimulators are doing is they're actually sending a signal to the spinal cord to override pain signals coming from somewhere else in the body. There's certainly a lot of there's been interest in looking at can you somehow do a spinal cord stimulator to bring motor function back, but nothing that has panned out so far.
Barbara and Jennifer are both commenting on wanting to be in clinical trials, but the age cutoff is 55. Do you want to say something about why they're seeing that?
Yeah, so for years and years and years, the typical age range for clinical trials in MS has been 18 to 55. In some of our neural repair trials, that age limit is being pushed up. We have several trials where we're going up to 65 now, and it's always going to be a battle between what the clinical trial designer wants and what we would like to see in the real world. The trial designers want as pure of a population as possible. They want people to have no other health issues. They're just as clean as possible. We want the real world, and so I do think in the neural repair, neuroplasticity world, I think it's very likely that we'll see that age, kind of 65 becoming the norm. Maybe, who knows, going to 70 in the future as we become, maybe a healthier population. And really, when you think about neural repair, you'd like individuals who probably are clinically fairly stable, not having active relapses with a lot of clinical fluctuation. So we hear the frustration of of that 55 cutoff, but do know it's that in some of the trials it is being pushed out a little bit.
Bonnie has mentioned that after years of being on DMTs, she was diagnosed with breast cancer. We also have Cindy, who was recently diagnosed with breast cancer and is being recommended to take Keytruda, which is going to make her immune system attack the cancer cells. So can you say something about
And we do see this, and best of luck to both of those folks in dealing with their breast cancer. Hopefully you sail through it and it's a speed bump in your rear view mirror in the very near future. We see, just because a person has MS doesn't mean they can't have other health issues, and unfortunately cancer can be one of those other health issues. So this is not an uncommon scenario. Depending upon what the cancer treatment regimen is going to be, if chemotherapy or some sort of immunosuppressant drug is going to be part of that chemotherapy, a lot of times we will stop the DMT at that time and really let the chemotherapy or the immunosuppressive drug serve as your MS treatment. We can treat MS with chemotherapy, older drugs like Cytoxan or cyclophosphamide, mitoxantrone or Novantrone are chemotherapeutic agents, and they do have an effect in MS. We don't prefer to do it that way because of the potential side effects of those drugs. But while the person is undergoing chemotherapy, we do frequently stop the disease modifying therapy and then kind of regroup once the chemotherapy is done. Sometimes those chemotherapies have a very long lasting effect. The immune system may be altered for up to a year. So we may not need to consider starting a DMT for some time in individuals dealing with cancer.
Thank you. Julia wants to know your opinion on stem cell therapies to treat MS.
So again, we always want to make sure we're all talking about the same thing. So when we're talking about repair strategies, usually we're talking about mesenchymal stem cells. So those are cells that are going to be given, either intravenously, maybe into the spinal fluid. There was an Italian study recently where they actually did a surgical burr hole into the skull and put the cells into a catheter into the ventricles themselves. And these cells are going to set up shop somewhere and hopefully promote repair. And then there's autologous stem cell transplantation or autologous hematopoietic stem cell transplantation. So that's basically like a bone marrow transplant. And so we really think of the HSCT, hematopoietic stem cell transplantation, as being kind of like a disease modifying therapy, if you will, just a very aggressive one. Now, in some of the HSCT trials, there have been improvements in function over time. Again, I don't know that those cells, that hematopoietic stem cell is directly repairing, or is it that it's so effectively stopping the inflammatory process that natural repair mechanisms are having a chance to set up. HSCT is, basically you're taking your own immature cells from your bone marrow, you're going to save them, freeze them. You're going to then use high dose chemotherapy to wipe out your existing immune system and then get those cells back intravenously and reboot a fresh immune system. Usually it takes about 30 days for those cells to engraft and start forming a new immune system. So you've effectively sort of cleaned your hard drive, if you will, and rebooted the computer. There are ongoing studies in the US. I mean, there's been a lot of positive research showing this is a very effective treatment. Most of the trials have suggested that the ideal candidate for that HSCT is probably under the age of 50 and has a very aggressive inflammatory component to their disease. We do have people going overseas for these procedures, going to Mexico prior to the Ukrainian-Russian war. The people were going to Moscow. That's become a little less appealing due to just the political situation. But just, if you're thinking about going overseas for something like that, just really do your homework, talk to your healthcare team, really look at the risks and benefits of doing something overseas like that.
Maureen had made an observation that you had said something about repair may be decreased as age advances and also the level of disability. And I think that may also tie into why some of these repair therapies may be more effective in younger individuals.
Yeah.
Do you want to say anything about that?
Yeah, so I think as we age and again, these MS lesions are older, there is that higher likelihood that there is gliosis or that scar tissue around the areas of damage. It also may be that there's more axonal damage. And so I think the more damage we have, I think the more challenging it is for these repair mechanisms to have a chance to work. It's just like disease modifying therapies. We know that the sooner we can get an individual with MS on a disease modifying therapy, statistically, the better they do in the long run. There's always this balance, where we would like to get people on DMTs early. We would like to get people into clinical trials early with neural repair trials. We also want to balance that out with hope. And so I think one of the worst things we can do as healthcare providers is completely squash hope. And so we always want to, say, okay, even if you've been dealing with MS for 30 years, 40 years, what can we do? What do we still have in our toolbox to help out? One of the biggest areas I think that is neglected in individuals who've been dealing with MS for a long time is aggressive rehabilitation. I'm a big believer in getting people involved with knowledgeable physical therapists, occupational therapists, speech language pathologists, because there's almost always something that can be done. And even if it's not improving function, adapting to disabilities, showing people better ways to transfer, better ways to walk, improving bowel bladder function. I think there's always something we can do.
That kind of answers Stephen's question. He said he was asking for recommendations for bedridden MS patients that were non-ambulatory. So I think you may have addressed that with that question.
Yep.
Susan wants to know what your opinion is the best therapy for patients with a dual diagnosis of rheumatoid arthritis and MS or lupus and MS.
Yeah, I mean, so there are a lot of times those individuals will end up on a B cell therapy. There's this kind of joke in the rheumatology world that, when in doubt, throw rituximab at it. So rituximab is one of our older B cell therapies, has a mechanism of action very similar to ocrelizumab. Um, so we do have patients with both diagnoses. Rheumatologists are very comfortable with rituximab. We do have individuals that we partner with the rheumatologist and say, listen, we can go with any of the B cell therapies, even though ocrelizumab, Kesimpta, Briumvi, these things are not approved for those other autoimmune conditions, but that they should work in there just like rituximab would. So I think probably the B cell therapies are what we use most commonly with those dual diagnoses.
Mike is asking an unusual question. He says, if your affected leg has extreme hyperextension, should he be concerned if after a knee replacement, he wouldn't be able to rebuild the muscle around the new knee because the leg mostly doesn't work?
Yeah, so I think that is concerning, and we've had that situation where the orthopedic surgeon has concerns about the hyperextension and what that's going to look like in rehabilitation after a knee surgery. I don't think it's a deal breaker. I just think it's something that is going to require some forethought and maybe some planning between the therapy team and the orthopedic surgeon. If that hyperextension is due to spasticity, so if you're having extensor spasms, we want to be as aggressive as we can in trying to manage that spasticity. Some people are hyperextending as a compensatory mechanism due to weakness in the leg, so they're sort of locking that knee in a hyperextended position so that it doesn't buckle. So I think there are different sort of rehab strategies, depending upon whether it's orthopedic hyperextension to compensate for weakness, or it's hyper kind of extension due to extensor spasms.
Deborah says she's been seeing a lot about MS being caused by parasites, or that people with MS have parasites. Is there any substantiated data on this and any known?
So there is no evidence that MS is caused by parasites, and in fact, there's this theory and some data to back it up, called the hygiene hypothesis, that maybe parasites in a weird sort of way are actually a positive thing, and that as humans evolved and we got rid of parasites, especially GI, things like roundworm and pinworms and tapeworms, that maybe our immune system really evolved to handle those things. And as we took them away from society, in people who have the right genes, that if you're genetically sort of predisposed to have an overactive immune system, maybe the immune system is more likely to overreact if you're not keeping it busy with a parasite. So there's some clinical evidence to support that. There were small case reports years ago out of Europe looking at individuals with MS who had tapeworms, and the tapeworms are bad. I mean, they cause nutritional issues, they can cause GI obstruction. So they had to be treated. But when these individuals had their tapeworms treated, their MS acted up after the tapeworm was killed. There are small studies that have been done at University of Wisconsin. I think there was one in Argentina, looking at using inactivated roundworm eggs to fool your immune system into thinking you had a parasite, and actually using that as an sort of to kind of treat the immune sort of effects of multiple sclerosis. So I think the parasites are good theory is interesting. I don't think it's proven yet, but there's some smoking guns that say, yeah, could be something there. I think the parasites cause MS theory, I don't think there's anything to back that up at all.
Thank you. An anonymous attendee says, based on age, how much time before seeing an improvement with mobility by utilizing physical therapy and Ocrevus?
Yeah, on the Ocrevus part first, when you head into a drug like Ocrevus or any DMT, I think a realistic expectation is that you tolerate the drug, that you're not having side effects. And then really what we're shooting for is this concept of NEDA, no evidence of disease activity. We would like you to have no relapse, no progression of disability, no new MRI lesions. Some people would add NEDA for no brain atrophy progression. If a person improves on a DMT, regardless of which one it is, I think that that we will take it. We're thrilled about it, but I wouldn't have people go into a DMT with the expectation that they're going to get better. Getting better with rehabilitation is going to be very individual. It depends upon what the nature of your disability is and kind of where you're starting at. So we never know with physical therapy and occupational therapy, how much improvement and how long does that take? It really is going to be very individual.
Thank you. Maeve said she was diagnosed 30 years ago with MS and did not take any medication, living a pretty full life as a single mom. She's now 71 and wants to try Ocrevus. Wanted to try Ocrevus 5 years ago. She was open to doing treatment, but due to COVID, the doctor refused to start her on the medication. She wants to try it, but her doctor will not permit it. Is she too old for Ocrevus?
So I think, as humans, we age at different rates, and we can see individuals who are 90 and still out running every day, and individuals who are 90 who are not as fortunate. So we have to acknowledge that there's a lot of individual variability in the aging process. But in general, as we get older, our immune systems do sort of calm down. The process is called immune senescence. And so if MS represents a dysregulated, relatively overactive immune system, and with normal human aging, it tends to calm down, you would think the need for disease modifying therapies is going to become less as we get older. And this is a topic of a lot of research out there right now. So factor that in, that as we get older, it may be less likely that you need to be on a disease modifying therapy. And then you need to look at the risks and benefits of that individual disease modifying therapy. The B cell therapies like Ocrevus are highly effective therapies, but they do work by killing a certain population of B cells, and they do have immunosuppressant potential. So my excitement about starting Ocrevus in a 70-year-old is not very high. I wouldn't say it's completely off the table. Again, it's going to be very individual, but I think that's probably where your neurologist is coming from, is that he or she may feel that your risk is more than your benefit with starting a drug like that.
I have two people asking similar questions side by side. So Teresa and Jim are both asking about smoldering MS again. Jim has added a little bit to that about, have you seen new MRI techniques to identify smoldering MS?
So again, this concept of smoldering MS is kind of, I like the forest fire analogy, is that, if MS is a forest fire and we put the forest fire out with a disease modifying therapy, or we just aging, it seems to go out, or there's still some smoldering embers left just below the surface. Maybe not enough to cause new lesions on MRI, maybe not enough to cause relapses, but just enough to maybe drive some very slow progression of disability. The MRI equivalent or sort of sequela of that is probably the slowly enlarging lesion. Maybe lesions where there's some paramagnetic sort of changes, or it's a sort of an MRI finding around the edges of that. But the slowly enlarging lesions on MRI are probably what results from smoldering inflammation. It is not an easy thing for the human eye on MRI to detect those slowly enlarging lesions. And so this is where limited use of things like AI, artificial intelligence, with some of the newer MRI programs may actually help us out quite a bit. So traditionally, when we look at your MRI, we're looking at your MRI in 2 dimensions. We usually do an axial study where you're kind of being sliced in this direction, and then a sagittal study where you're being sliced in this direction. With these AI programs and some of these new metrics, you can look at the brain 3-dimensionally, and some of those programs are much better capable of detecting the slowly enlarging lesion than we are by just looking at that. So I think, for instance, we here at Shepherd Center, we're partnering with a group in Sydney, Australia. We are using their software program, which is an AI-based program, to look for these slowly enlarging lesions.
Thank you. Ben wants to know your thoughts on going off-label for DMTs in persons with primary progressive MS.
So I think different healthcare providers have different thoughts on using things off label. My thought is that, if we can use something safely and if there's some, rationale, whether there's a small study or there are, in vitro, sort of lab-based models to say, even though this drug is not FDA approved for what we're thinking of using it for, there's some rational, reason why we might be able to do that. I'm certainly open. We do things off label all the time, and a lot of what we do for pain management in MS is off label. Everything we do for fatigue management in MS is off label. I think where it's a little more challenging is when you get into disease modifying therapies, because you've got the cost of the drug. You and I as healthcare provider and individual living with MS, we might say, we want to do this. Your insurance carrier may say, well, I'm not on board with it. I'm not going to pay for that. So there's that challenge. And then we need to also think about, not only the potential benefit, but the risk. If we're using something off label and it has very little risk, I think that equation looks different than off label where there's a lot of risk. So off label, I think is done in medicine all the time, and it's certainly open for discussion. In primary progressive MS, I mean, way back in the day, I mean, there were studies with glutathione acetate or Copaxone, and it was a negative trial. But when you did a subgroup analysis and you looked at only the people who were progressing more quickly, there was a glimmer of positivity. And so we would have discussions with individuals with PPMS about the off-label use of Copaxone. And now we have one FDA-approved therapy in Ocrevus, and so that's certainly an option. But I think off-label discussion is certainly something that can be put on the table.
That study that was done with PPMS and Copaxone, that was either 10 or 12 years later, they revisited the patients who were allowed to stay on Copaxone, and their EDSS was lower consistently on those that stayed on Copaxone versus those that went off.
Yep.
So there was a clear benefit when we were able to look back at that trial.
Yep. Good point.
It's not that it really improved anything, but it kept them from progressing at the rate that those that were not on medications were
I think
progressing.
that was such a great example of a drug that was very benign. I mean, very, very low side effect risk. There's the hassle of using it, just the injection, but in terms of actual risk to the person with PPMS, I mean, it's minimal.
Right. Angela wants to know what your opinion is on treating the EBV virus to help with MS symptoms.
Yeah, so a lot of interesting stuff in the past few years on Epstein-Barr virus and MS. The huge military study showing that there was a correlation between the timing of people, picking up Epstein-Barr virus and the risk of developing MS. The Stanford study showing kind of what the receptors were on the Epstein-Barr virus, what was being attacked in the central nervous system, and the antibody that kind of linked the two. We are very hopeful that those lead to some treatment possibilities in the future. I think where the evidence is right now is the Epstein-Barr virus is that environmental trigger combined with the right genetics that sort of may send someone down the MS pathway. Is MS caused by an ongoing, inflammation driven by Epstein-Barr virus? I don't know that we know that for sure. There is a drug in testing right now, a vidofludimus oral agent that has some antiviral properties, and there is some hope that they're going to get some maybe answers to whether a drug with antiviral properties has positive effects in multiple sclerosis. If we had an Epstein-Barr virus vaccine, I think it would make a big dent in the incidence of multiple sclerosis. Could we prevent MS from developing in the first place if we could prevent Epstein-Barr virus infections? So I don't have an Epstein-Barr virus treatment that I can prescribe right now or that I'm aware of. So I think it's a good thought, but I don't know that there's anything I can do with it practically right now.
That ties into Karen's question. If EBV is causing MS, have antiviral drugs ever helped or stopped or reversed disability?
Yeah, not yet. I mean, it's a great thought. And again, this study drug that I mentioned earlier, the vidofludimus, is certainly trying to look at that. The problem with well, not, it was not a problem. It's a challenge with that drug is it has properties other than antiviral. It's anti-inflammatory. So, you know, if it is positive in its trials, was it because it's antiviral or because it's anti-inflammatory? I don't know that we'll have the answer to that immediately. But no, I think if we had an anti-Epstein-Barr virus treatment to prevent it or to treat it early on, it's certainly, you know, possible we would change the course of MS.
Thank you. Fred and Dana are both asking about your recommendations for vaccines, particularly if you're on a B-cell drug.
Yeah, so be sure to talk to your healthcare team. You know, there are recommendations for before starting a B cell therapy, things that we want to get on board. Once we start that B cell therapy, we are going to impair your body's ability to make new antibodies. And so when you think about a vaccination, you're generating both an antibody response and a T cell response. We don't impair the body's ability to make a T cell response to vaccination. The question is, how effective is that T cell response? And the other challenge we have is we don't really have blood tests to measure that T cell response. For a lot of antibody immunizations, we can measure your antibody response to vaccination, but again, no commercial tests for the T cell response. So we know that your antibody response is going to be potentially impaired, so you may not get as much benefit from vaccination. Doesn't mean you shouldn't do it, but we have to acknowledge that you just may not get as much benefit. So I would say talk to your healthcare team. You know, there are vaccinations if you're looking at live attenuated viruses that might be no-nos in people on B cell therapies. So again, you go through that with your healthcare team. One of the ways of getting around the impaired antibody response to vaccination, if you're on a B cell therapy, as it relates to COVID, is to use one of the monoclonal antibodies. So, and we did this quite a bit during the Delta surge of the COVID pandemic. If we can't, you know, have your body make good antibodies, let's just give you the monoclonal antibody, essentially the antibody passively, so that your immune system doesn't have to do anything. The monoclonal antibody that we had during the Delta surge, unfortunately, as the virus mutated, the antibody became ineffective. So there is a new one now called PEMGARDA that is out there that is, at least for now, a monoclonal antibody against the current strains of COVID virus. It is available. I think fortunately COVID has become less of an issue compared to where we were back in 2020 with the Delta surge, but that PEMGARDA is available for you to look at with your healthcare team.
I've had 2 doses of the PEMGARDA so far. They can be given 3 months apart, and I've had virtually no problem with those infusions, even though they're really concerned about, it was a small group of people that were in the clinical trial, and there were very few problems. So they keep you for 2 hours for observation afterwards, but I've had no problem
Where did you
whatsoever.
end up getting the PEMGARDA at?
I had to go to another major health chain hospital to get it at their infusion center. My community hospital, where my infusion center is, would not do it.
You know, we've seen the same thing here, and that it seems to be a little bit less available than some of the older monoclonal antibodies. So we've been using a private infusion. It's a franchise infusion center that does have it in the Southeast.
Okay. Yeah, you kind of have to advocate for yourself on this one. It took me about 3 months to get it after
Yeah.
it was approved. Heather is saying my MRIs have consistently shown no changes or new damage, but my mobility has declined. Is this normal to have progression if the MRI shows no changes?
So this is sort of that definition of PIRA, PIRA, or progression independent of relapse activity. So that's it, you know, that story. And I think one thing that's important for the MS community to hear is that we and the medical community, we hear you and we believe you. We know this happens. I know it's frustrating for people to go to their MS Teams appointment and be told that your MRI is stable, and you go, but I don't feel very stable. I know I'm getting worse. We know that can happen. I think right now, until we see whether the BTK inhibitors are going to provide some answer to that problem, we're again, big believers in rehabilitation and just pushing back as hard as we can with physical therapy, occupational therapy, exercise programs to just try to maintain that function and adapt where we can't maintain.
Thank you. An anonymous attendee wants to know if our brains can remap new pathways to improve mobility with exercise.
I mean, that is the suggestion. There was a study years ago where they looked at people with fairly significant relapses, MS relapses who had mobility issues. Both groups got standard 3 days of IV Cymedrol. One group got aggressive rehabilitation with the Cymedrol, one group didn't. The group with the rehabilitation performed much better. And the suspicion was it was through neuroplasticity or rerouting. One of the challenges with plasticity is kind of measuring it. We really can't measure plasticity with standard MRI. There's some research techniques out there that where you could potentially do it. So we sort of assume when people have improved function through rehabilitation or research pathways or this PONS device that it's through plasticity.
An anonymous attendee is also asking, are cervical lesions responding better for neuroplasticity or brain lesions?
I don't know that we know that at this point. We would assume that if you have some sort of mobility issues, that there probably are spinal cord lesions, either cervical or thoracic, that are at least in part contributing to that. And so, a lot of these studies on plasticity have included people with cervical spine dysfunction. The PONS study, the Helios PONS device, specifically looked at individuals with gait dysfunction, and they didn't specify in that study that you had to have a spinal cord lesion, but I can almost guarantee you that the majority of people in that study probably did have spinal cord lesions.
I think you may have answered this question. Joseph is asking if there are any studies that you know of that are targeting remyelination right now.
Yeah, I mean,
And
yeah, quite a few. So again, if you go back and look at that, the program from last month, look at the PowerPoint. I have several of those listed that are ongoing at this time.
we are coming up on the end of our hour. There are a number of questions still in the Q&A. The majority of them are symptom related, so they are not appropriate for this particular webinar. We're only talking about reversing disability. Our next, do you want to take a couple more questions, or do you
Sure.
want
Sure,
stop?
a couple more.
Lisa wants to know what can be done for slowly enlarging lesions, and how will this help if they can be identified?
So again, if slowly enlarging lesions are sort of the MRI manifestation of PIRA or progression independent relapse activity, it's not 100% clear that our existing disease modifying therapies, even our really good ones, address that. So we'll have to see what the BTK inhibitors look like. I think for right now, we just want you on as aggressive of a disease modifying therapy as is appropriate for your situation.
So the symptom management questions that have not been answered, bring your questions to us next Monday at 3 o'clock. I will be working with all of you on managing symptoms specifically. So bring those questions. I'm really sorry that we didn't have time to get your questions answered, but this webinar was specifically targeting repair and reversing disability. Is there anything that has come out with these questions, Dr. Thrower, that you feel you want to wrap up in a closing statement?
I know that we've come light years in our ability to stop MS for a lot of individuals. This goal of NEDA, no evidence of disease activity, I think we do achieve that in a lot of individuals now. in spite of that, we know that there are a lot of individuals out there living with disability. Either the disease modifying therapy wasn't completely adequate, or they had MS for years and years before we had, the current disease modifying therapy. So just, sending out a message of hope that, we know you're there, we hear you, and that the research is aggressively, ongoing towards answering that question. And it's really, you're not fighting this fight alone. So, people living with disability with MS, there are individuals with spinal cord injury and stroke and, traumatic brain injury. A lot of this repair research and plasticity research is also being done in those fields. And it's very possible that, some of our advances could come from the spinal cord injury field. And in some ways, their model is easier to work with in that it's, one site of injury and there's not an ongoing inflammatory autoimmune process. So, keep your fingers crossed that we will have answers to this in the future.
Thank you. And just a word of hope for those of you who have had MS for years and feel like kind of been left in the dust. It was 27 years after my symptoms started before I was able to get onto a medication, and 6 medications later, I've really recaptured things. I was not walking any more than just a few feet at a time. So just keep trying. If you've got a doctor that's not willing to treat you, it might be wise to get another opinion, because most of the docs that are in the MS arena now are willing to treat, particularly if you're under 70. So our next webinar will be next Monday at 3 p.m. Eastern Time. I will be answering questions on symptom management. And then also Wednesday of next week, in honor of Hispanic Month at 3 p.m. Eastern Time, we will have Dr. Mirla Avila speaking with us, and it will be a Spanish language webinar. So she'll be dealing with working with our Spanish language viewers on management of MS and your symptoms. Thank you all for being so patient with us. And again, I'm sorry for those of you that had symptom management questions that we didn't get to answer. This webinar was recorded live on Facebook, so it will be on our public Facebook page, the Multiple Sclerosis Foundation, and within a week or two, it should be up on our YouTube page. And again, in the chat, if you scroll all the way to the beginning of the chat, there is a link for the webinar a month ago where Dr. Thrower had his slides on this. And he said if anybody wants his slides, he will make them available. So if you'd like his slides, just respond to your registration email, and we will see to it that you get a copy. Thank you all very much. Take care. Bye-bye.